Welcome to the University of Washington School of Nursing Voices of Nursing podcast, where we dive deep into the diverse and inspiring stories from the heart of healthcare. This is Voices of Nursing. Welcome, Lydia Drumright, to the University of Washington School of Nursing podcast. And we're going to start today with talking a little bit about yourself. So if you wouldn't mind introducing yourself and how you came about coming to the School of Nursing.
Yeah, well, thank you so much for having me. It's a delight to be here. And I think my sort of background coming to the School of Nursing is quite unusual. So I'm a clinical assistant professor, and I will be joining the faculty in January as a research assistant professor. So I have a bachelor's degree in biochemistry, an MPH in health education and community health, and a PhD in epidemiology. I do not have a clinical nursing degree or another clinical degree. So I am purely research. That being said, I've spent a lot of time in healthcare settings. So just starting back from my degree in biochemistry and cellular biology, I was a bench scientist. I worked in the infectious disease laboratory in the Salk Institute, and I worked in psychiatry over at UCSD doing genetic research. And then I got an MPH in community health and health education, which covered a lot of sort of needs assessment and qualitative research. And I also at the time worked for the Los Angeles County Department of Health and did outbreak investigation. And then I went on to get my PhD in epidemiology, where I did both community epidemiology in places like San Quintin in Mexico, and then for my degree, I ran clinical epidemiology studies predominantly in HIV. And then I moved over to the UK, and HIV, STI work wasn't really open. The communities are a little bit smaller, so I actually went to work in healthcare-associated infections and working within the NHS, doing in a research job. And that's where I started working really closely with healthcare providers, and not just medical doctors, which I worked with when I was doing my PhD, but also nurses, pharmacists, allied health professionals, and really gained an appreciation for both the work they do, the challenges they have, and how valuable they are to the healthcare system. I also did a lot of work in low and middle income countries, and I started working in sort of interdisciplinary work. I led an interdisciplinary research center with somebody else at Cambridge, and really started gaining an appreciation for health informatics, which is predominantly what I was doing, but the value of it, not just in healthcare, but also in public health and around the world, and how we could utilize it, how it could really help different healthcare providers with the things they needed help with to deliver the best care to their patients, the things that they struggled with. And so that became my passion. And when I came back here, I naturally fit back into HIV epidemiology, but I also wanted to do health informatics research. And so I've been working between the School of Medicine and the School of Nursing, and went ahead and got acquainted with School of Nursing and applied for this research position. So I'm really looking forward to being part of the School of Nursing, especially given all the innovation in this area that's happening right now.
Lydia, that was such a lovely summary and so much to ask about. So I don't even know where to begin in your background. But one of the questions that came to my mind is you were talking about providers in general and how you'd worked with physicians primarily and then had shifted your focus into working with nurses. At School of Nursing, something that I've heard is not everybody realizes that nursing is a science and that there is science and research as this backbone of nursing education. And so I was just curious if you could elaborate a little bit for just the general public of what makes nursing science a little bit different and what makes your research focus a little different than someone who might be focusing in an area like medicine.
Yeah, so I think this is a really interesting question because I don't always differentiate them that much because I see the care of the whole human as the important part, but certainly medicine and nursing, at least in the everywhere in the world, but in the United States, takes a certain sort of separation between who takes care of what. And so I think, the way to think about medical versus nursing science, oftentimes medical research focuses, but not always, because we have primary care where nursing and medicine come together. So this is just more generalization for the audience. A lot of medical research focuses on things like clinical trials or, the best surgical procedures, things that actually doctors are responsible for. And a lot of nursing science focuses on the aspects of how the patient learns to become their own advocate and work for themselves, or what types of care beyond just sort of the procedures and the drugs that a patient needs to do well during their ill health and to get better. So there's a lot of outcomes research in nursing that I think people don't appreciate in nursing science. But I tend to bring the two together, and oftentimes I bring the two together because we do a lot of work at the Center of Primary Care. And as you know, a nurse practitioner, depending on the state you're in, can be a primary care provider just like a physician can be a primary care provider. And so they often face the same challenges as well. So we sort of separate them but bring them back together.
I love that. It very much centers the patient and the experience of the people that they're caring for. Love everything about that. In your answer, I also heard you talk about your time with the NHS. And just from a curiosity standpoint, as someone who's never interfaced with the national health system in the UK, could you tell me a little bit about what that was like? Maybe what's different about your time here and what's different about, centering the patient in that system?
Yeah, I think that I realized when I came back there were more similarities than differences. But I think to start with, just thinking about the whole system. So I know that healthcare providers depends on the organization they work for, the healthcare organization, they can have challenges with the healthcare organization in terms of sort of not having the same goals as them, for example. But in the NHS, this is more complicated because the NHS is one huge organization that has a set of rules and a set of ways of operating. And all the different hospitals and tertiary care centers where I predominantly worked, they actually have different challenges and different sets of patients. And so they have some flexibility because they get their own budgets, but they don't always have the kind of flexibility we have here, the opportunity we have here to tailor things to their patients. So there are often challenges. There are challenges with regard to funding and money. So the NHS buys everything and pays for everything. Everything is free at the point of care in the NHS. But that also means that if they can't negotiate the appropriate pricing with a drug company for the country, then that drug is not available to their patients. Or a tool for surgery, and that can be very frustrating to the healthcare providers, particularly the doctors in this case, because they know that it's out there and it's available. They go to conferences, they know other providers have it, and they can't have it. And that is a slightly different challenge. I think everywhere too. Again, it depends on how the organizations run. We have lots of different organizations here. I know Mayo Clinic is run by the providers, which is probably a very different experience. Where it's not run by the providers, there's also kind of sometimes a frustration between feeling like fixtures in the environment. So when I started my work, I really was interested in vulnerable populations, underserved populations. And it was a hard change for me to think about going and working with healthcare providers in the NHS. Then I really appreciated them as an underrepresented, underserved population because they're treated like fixtures in the environment. And, you know, they're really, I think everyone who goes into healthcare is driven by the same desire to help their patients and do the best for their patients. And I think that can be very frustrating when you don't feel like the organization is doing the same thing. And that's not always the case in the NHS, and it's not always the case that that's not the case here.
Right.
But I just really learned to appreciate their challenges, their needs, and, you know, how their hopes and desires for their patient, for being the best provider they can be, can be interfered with by, you know, a lot of environmental, structural things that maybe they shouldn't.
That is really interesting, Lydia, because we sometimes think about more, everywhere else is better, right? But every system has different fallbacks or different drawbacks. And so it's good to hear about what are some of those trade-offs that you make and maybe things we can learn from to evolve, but also what are some things that we also have to take into consideration. So you're currently working on a project that links technology to optimized healthcare outcomes, because we've been talking a lot about healthcare outcomes for the audience today. So can you just tell me a little bit about the work that you're doing and why the work is important and how it works to influence clinical decision making? Maybe tell the audience a little bit about, you know, very basically what it is.
Okay, yeah. So what we have is an application, just like the applications you might have on your phone, for example, or ones you go to on your computer to look at something. You know, Uber is an application, right? And our application is called the Clinical Opioid Summary with Prescription Integration, and that's like a big mouthful. So we call that COSRI because the prescription is RX, of course. And this is an application to help providers view data from something called the PDMP, which is a database for all controlled substances prescribed to people. Well, it's not when they're prescribed, it's when they're collected. So the pharmacists register every time a controlled substance is collected. Every state has a PDMP. And this is actually part of the rollout of a whole host of things that the government, the federal government, has done to address the opioid epidemic. And I'm sure you're aware, and probably a lot of the audience is aware, we're in the fourth wave of what we call the opioid epidemic. That was marked by extreme increasing fatality due to opioid overdose. That was predominantly now the source, we believe, was driven from misuse and overuse of opioids in healthcare settings, so prescribed for pain relief. Lots of people will be familiar with all the trials going on with Purdue Pharmaceutical right now and the drug called OxyContin, which isn't the only opioid out there, but part of the issue. We've gone through different waves. Right now in the fourth wave, we are seeing an increased fatality due to what we call synthetic opioids, predominantly fentanyl. It's in the papers a lot. I think people have heard a lot about it. So part of what the federal government is interested in and supporting is appropriate prescribing of opioids and helping support healthcare providers with this. And I want people to appreciate that all the healthcare providers you have out there are trained in specialties, so sometimes prescribing with certain things is more of a challenge. They're not particularly trained to prescribe every single given drug. I don't know if people have seen the manuals for drugs, but they are huge tomes, bigger than dictionaries. There are a lot of drugs out there, so it's complicated. Mm-hmm. And so what we've done is helped providers access the PDMP. In the state of Washington, we heard that from former research and interacting with the Department of Health, that healthcare providers were struggling to access PDMP. It was available, but they weren't accessing it. The CDC provides a set of opioid prescribing guidelines that they would like everyone to follow. The states have mandates on top of that, which might modify that, but everyone's sort of working toward the same goal. And that's when you prescribe opioids, particularly for the first time, or when you're increasing a dose, something like this, you want to be checking the PDMP because you don't know if another prescriber gave that patient opioids. And as we know, part of the epidemic created opioid-seeking behavior where patients who actually became dependent on opioids would, visit different doctors because that's a way to access a substance you're dependent on. And so they weren't accessing it. They were having difficulty accessing it. Part of that was just it took a long time to log in. It was complicated. It didn't fit their workflow. So we built them an application to fit their workflow. We piloted it in 2 primary care clinics in Washington, one in a rural area, one in a not very wealthy area. And these clinics were independent clinics owned and run by nurse practitioners.
Oh, wow.
And they love it. They utilize it. We did a lot of evaluation against it, and they're utilizing it well, and they are continuing to utilize it after about 2 years now it's been running. And they've decreased overall. We look at opioids as morphine equivalents because each opioid has different strengths. So we bring all the strengths back to morphine equivalents by, if you have a certain dose of OxyContin, you can bring that over and say, what is that in a morphine equivalent? So they have reduced their morphine equivalents that they're prescribing, and they have reduced their contraindicated prescribing. So there are other substances, sedatives such as benzodiazepine, things like that, where if you combine that with an opioid, you can also have not an overdose, but a fatality because of the combination. So the way people overdose on opioids is they just stop breathing, right? It's a central nervous system sort of depressant, and they'll stop breathing. And so combining 2 depressants will cause them to also potentially stop breathing.
So this is being tested at a nurse practitioner setting, and you're getting this data and information about how well it's working, and you're seeing the outcomes. Is there a plan to expand that out beyond this?
There is indeed. So we've been working with ONC and the CDC via a contract, so a contractor, to look at ways to utilize this tool. And next year, so one of the areas we've expanded it to is actually RUW medicine. They're using it in their chronic pain clinic. So the Center for Pain Relief is utilizing it. We also have a tool that we delivered to the Center for Pain Relief, which is another IT tool, but it's patient-facing. And the patients fill in forms about key important features. If you have depression, you might actually experience pain more severely than if you don't.
Absolutely.
So they can treat some of these other problems if they have this information. So we've given them an app where we're combining the 2. That will be ready to start pilot testing with them in the fall, and they've been designing that with us. And we are partnering right now with the state of Nebraska to pilot COSRI within the state of Nebraska.
Wow, how very exciting. So this will now be an interstate, cross-state effort. That's so very exciting. And how cool to see it starting to expand into the Midwest. Such a relevant topic everywhere, but a really exciting tool. And I'm so excited to hear more about how it's applied and what the outcomes are in other places.
Yes, we'll have to meet in about a year.
Yes, please. Let's do a follow-up episode.
It takes a while. But,
Yes.
And one of the things, like if people are really interested in the technology, one of the things that makes this possible is that we are utilizing a technology called Smart on Fire. Those are tools to work with FHIR. FHIR is the Fast Health Interoperability Resources standard of communicating between different health systems. I think people have heard of different electronic records, Epic and Cerner, and so in order for them to communicate between each other, they kind of need to use a single standard. So because they have that standard, there are a set of tools that go with that standard where you can build applications for that, and then we can interchange parts to change the relevance per state.
Excellent.
Yeah.
Who would have thought that there's so much that goes into just having that appointment with your practitioner and having them have the correct information and be able to serve you well? Thank you so much, Lydia, for sharing this with us. And I'm really genuinely excited about the next episode. And a year from now, or however long it takes, that'll be wonderful. My next question is, you shared your background and your path to getting here and a little bit about the application, and we're very excited about the outcomes we're starting to see with that application. I'm just curious about your personal passion and your personal history that brought you to this focus on technology and optimization. I mean, there's a lot of things that you focused on in your doctoral focuses, and you've done so much work and research in epidemiology. What in particular led you to this moment where you're focusing on technology and optimization?
Yeah, I kind of feel like it's a culmination of my experiences. So starting way back when I was a doctoral student in epidemiology, we always were faced with challenges of collecting together different bits of information that we needed to understand the epidemiology of a certain situation, condition. So in this case, I'm predominantly talking about primary HIV infection. That's where I used to work. And we had different types of data and different data sources. And it was always kind of a challenge to capture those and bring them together. And then we realized the patients might answer questions for us, but they also had clinical care. So that was sort of my introduction to thinking there's got to be a better way to sort of collect all this data and bring it together and put the least amount of burden on everyone involved, so providers and patients, or what I would call a research participant in this case then. And then I went over to the UK, and I started doing a little bit of work on some innovative health informatics, working with, when you're absent in the UK, they actually record the reason for your absence, so we could look at healthcare worker absence and do surveillance on influenza-like illness, and saw that actually we could start an earlier alert system by the healthcare workers going off sick for influenza than they could in primary care.
Yeah.
So a lot of kind of exciting things like that. And then I did a lot of work, as I said, internationally in low and middle income countries. And in those settings, there was tons of information, but a paucity of collecting it together and bringing it together. And then, of course, I had this role as the director of research for the first EPIC instance in the UK, which was at Cambridge University Hospitals. And and then I would talk to the providers and ask them what they needed. And I would think, we can bring together the information for use. So one of the things that I appreciated that providers didn't have, they had all the information in one place. That was great. But if you open one of those screens, it is overwhelming. It's like, shoom, that's a lot of information.
Yeah.
And so actually I realized, people need this processed for them. And we can work as a team to process this information and help providers provide care, because there's no difference in the NHS and here with how little time a provider has to look after their patient. Right. And it doesn't matter if they're a nurse or a doctor or a pharmacist, they have very little time with their patient. Yeah.
Universal
That is
challenge.
universal. Yeah, you don't get more time with your patient if you change the structure of the healthcare system.
So however you can reduce that cognitive load and really get it to where they're just seeing what they need to see is a big boon.
But I just want to throw in that what they need to see is important and when they need to see it. And that's about, I keep talking about the partnership, right? So the other issue that this is sort of my big issue with the way tools are built. They're not designed with the providers. There's no user experience interaction. There's no understanding of what the provider is going through. And so they're often placed in the wrong place. So there's a good tool, but it's not going to get used.
Right. Which, again, another challenge that we see in multiple different industries where you're not taking the human into consideration in the interface, right? It's all about, we got to build this because this is what we can build, and the limitations are more focused on development versus being focused on how it's going to be implemented.
Absolutely. And as an epidemiologist, it's all about the humans, because our joke is always like, this would be so much easier if humans didn't get involved.
Oh, wouldn't this be so much easier to track human behavior and diseases and all these things with no humans?
People have behaviors, and that means a lot of variety, and that makes us have enjoyable lives and, have a lot of fun out there in the world, because you don't know what you're going to get.
Yes.
But on the other hand, that also complicates the way we deliver interventions.
Absolutely. It differentiates from other sciences where you're observing objects and adds that variability, which is so exciting. But man, humans do like to complicate things.
Humans are a lot of fun.
They sure are. Well, thank you so much for telling us about this and for sharing about this more human-centered approach to provider information sharing and what you're doing on the back end to really use providers' input in developing these solutions. So as we wrap, is there anything you want the audience to know about your work, about this kind of research in general, maybe where things are headed? What do you think people really need to know?
Yeah, I think I'm guessing that the question on everybody's mind, and they're probably a little disappointed at this point in time, they're saying, why didn't you talk about artificial intelligence, AI, it's the buzz, right? And you've got ChatGPT, and you've got, Google has their own tool, everyone's got their own AI tool. And I think that I just want to tell people to sit tight. So with technology, there is sort of this hype. That's where we are right now.
Absolutely.
There is a trough where everyone gets disillusioned because nothing happens in the hype. And then we get to a place where we can have some innovation and start working. But, I just want to remind people, especially people who might be interested in working in this area. Hopefully there are young people listening who are thinking about their careers. I think this is a great way to go. I think that we are at the very, very beginning of utilizing tools in IT for and technology for healthcare and for advancing healthcare. And I want to remind everyone that you don't need a big step change. You can use incremental changes. So oftentimes we get a big step change, and I just want to use the example of antiretroviral therapy. We had nothing and people died from AIDS. And then in 1996, we had combination therapy, and people no longer had to die from the conditions related to HIV. And that therapy wasn't terrific, but it saved everyone's lives. Today we have amazing therapy. So that was a huge step change, kind of earth-shattering. But all these little changes that have gone on in the background, nobody's noticed, except for maybe the people who are living with HIV, because their lives are so much more simple now. Instead of taking a bowl of pills, they take 1 pill a day.
Yes.
2 pills a day.
Yes.
And live longer than ever and have less inflammation. So if we just parallel that to sort of IT, yes, there are hypes, yes, there are things people want, yes, there may be a big step change at one point, but it's the small incremental changes that'll make all the difference.
And in that way, people may feel a little bit like, oh, I've missed the boat on being able to make an impact in this area of artificial intelligence because everybody's talking about it, right? It seems like something that either you've been an early adopter and you've made a big impact already, or you've kind of missed the boat. And so what I'm hearing from you is that actually human-centered approaches to research are more important than ever, especially now when folks can automate things and lean on artificial intelligence. You have to have that human component, that judgment, that engagement and feedback.
Absolutely, and I'm going to tell you the boats haven't left the bay, and a lot of them are sinking. So there is plenty of time to get on board, and this is, I think, we're looking at a 10, 20, or longer year plan on making this really work for healthcare and public health.
This is where the work begins, right?
That's right.
Well, Lydia, thank you so much for joining us for our podcast today. You've been an absolutely wonderful guest.
Well, thank you so much for having me. It's been a delight.
Thank you for tuning in to University of Washington School of Nursing's Voices of Nursing podcast. Join us next time as we continue to explore topics vital to nursing, health, and well-being. Until then, stay informed, stay inspired, and stay engaged. And don't forget, follow Voices of Nursing wherever you listen to your favorite podcasts so you'll get every show as soon as it's released.